Dr. Villarino, and she prefers that we call her Elsa, so thank you, Elsa, because I feel more comfortable with that as well. Has a long, illustrious career in public health, and I think we're really fortunate to have her back here in San Diego at this stage in her career, and we can take advantage of so much of the information that she has to offer. Elsa is a medical epidemiologist. She started out in the Epidemic Intelligence Service program at the CDC, followed by a preventive medicine residency at the CDC and at San Diego State University. She received her MPH back in 1991. She's worked for the CDC for 31 years until 2013. Prior to that, she was working as the director of the CDC's Tuberculosis Trials Consortium that was based in Atlanta. And then from 2013 to 2019, she was the director of the CDC's Mexico office and public health attaché for the Health and Human Services, and was detailed to the U.S. Embassy in Mexico City, Mexico, where she worked with the Mexican Ministry of Health, as well as other agencies, universities, and NGOs. So very, very well connected both in the US and in Mexico. And then in 2019, she finally decided that she had enough of the federal government. So she retired from her federal public health position, but she didn't leave public health. She moved to California and worked for 2 more years as an assistant public health officer, a TB control program director, the director of special investigations branch for long-term care facilities and acute care hospitals, and COVID-19 response, all for the Santa Clara County Public Health Department. So very busy up there over the last few years. And now she's currently part of the investigations and response team at the California Department of Public Health, Healthcare Associated Infections Program, where she's doing consulting and doing a lot of work with COVID-19, et cetera. But I think one of the things that's really great about having Elsa speak with us today is that she's coming to talk about how students in public health can understand how they can have opportunities to investigate as well as publish on the work that they're doing in a public health setting. And she's had opportunities to mentor multiple people throughout her career. And I think that if we can get her working with us and mentoring some of our students and junior faculty as well here, we would be very, very, we'd benefit greatly. And the last thing I'd just like to say is I had the pleasure of originally meeting Elsa in our master's programs together at San Diego State. So our histories go back a lot of years. And I'm just really thrilled to have you back here in Southern California. So thank you, Elsa.
Thank you. And so with that, we'll start. My presentation is geared to you that are my colleagues and mentors and teachers, to those that are currently studying public health epidemiology. I wanted to transmit how great a career it has been for me and how much I've learned, and how, as the years go by, I have the privilege of using my knowledge that I acquired from also my teachers to then become somebody who can mentor and who can give more to public health. And right now is the time that we need it more than ever as a society. So like Richard said, after I retired from CDC, which was one type of experience with public health at a very high in terms of view of how much to encompass, I went to work in Santa Clara County, which is also a very large county within California, such as San Diego, a little bit smaller than San Diego, but equally complex, equally large. And it gave me a great opportunity to serve, even though I went to work initially as the TV controller, an area that I was very familiar with, and it was very easy for me to think I would do a good job. 3 months into my assignment, I got reassigned to be the lead of the Special Investigations Unit of the Emergency Operations Center that was stood up for COVID. That was quite interesting to me, both because it just, all the things we didn't know, and I had an opportunity to be there from the ground up. And also because at the same time, for example, people came from the CDC to Santa Clara to help us with the investigations. That was very end of a circle, where I used to be the person that went out to counties, and now I was in the county hosting my CDC colleagues that arrived initially thinking they were gonna stay for a few days. Actually, they had come, one directly from Chicago, where a few cases have been investigated in community cases, but that had not presented with community transmission. And we really didn't expect, as you all know, what came afterwards. So in this presentation, I would like to describe to you those early investigations that we did, and how also by mere will, we were able to enrich them, the epidemiology, with the genomic sequencing. Nowadays, you cannot think of COVID-19 without thinking of genomic sequencing, like if I'd always been there, but that wasn't the case back in January of 2020. And we also were very lucky that we had good partners with UCSF and with BioHub, in that we created a good surveillance system in the long-term care facilities in Santa Clara County, where we could do further investigations of outbreaks using genomic sequencing. So like I was saying, genomic sequencing, microbial genomic sequencing has always, or at least from the 70s, has been used for analysis of outbreaks and for understanding disease transmission and disease transmission's patterns and advising on control methods. But it wasn't really until 2005, with the advent of the new generation sequencing, and of course of the high computing capacities that we have now, that we can say that the era of genomic epidemiology really started. Nowadays, you couldn't imagine that you would do systems such as analyzing our foodborne outbreaks and our food safety. It used to be with pulse field gel electrophoresis, and now everything is with genomic sequencing. In fact, every single public health laboratory in the United States has a genomic sequencing capacity for salmonella, for example. We also know that for influenza, analyzing the strains on that come from the Southern Hemisphere, so we can then produce the vaccine that is going to be used for the next season in the Northern Hemisphere, is done through genomic analysis of the strains. And of course, tuberculosis, which is my main area of interest. Every single case of tuberculosis that is identified with a culture gets sequenced, and that is something that allows us to trace the origin of as imported or local for every case. When we were in January, in early February of 2020, we knew that the CDC intended to sequence every specimen that they could, because we had CDC advisors with us. But we also knew that there were it was very skepticism that you could actually do analysis of an airborne virus that is very rapidly transmitted, and that it has a slow evolutionary rate of only 2 mutations per month, that you could actually use genomic sequencing to be able to resolve or dispute epi links that you had. however, we, like I said, had the ability to understand that CDC was going to be doing genomic sequencing, and that more closer to us, UCSF had developed a technique that could sequence the COVID-19, the SARS-CoV-2 virus, and that they, as other academic institutions, didn't have access to as many samples as we did, where we were in the county health department. And we, at the beginning, were the ones that did the testing first by sending the specimen through the public health lab in the county, had to go to CDC, and then the public health laboratory in Santa Clara County got, of course, the technique from the CDC, like others, and we could do it. Also, our public health laboratory director was very savvy and wise, and from the very first specimen that was collected and sent to the CDC, he kept a copy of all the specimens and developed a specimen bank. So anything that didn't get sequenced by the CDC, we could do it ourselves when we had the capacity. So we had the cases first in travelers. They were in January, and they, because Santa Clara had lived in 2003 with the SARS case epidemics and pandemic that happened then, no one really thought that they were going to be the beginning of a big outbreak. They thought it was going to be somewhat self-limited, and we were very interested in those cases, created a lot of isolation guidelines and testing, but we weren't testing any asymptomatic household members, for example. We were very limited to who we could test and what type of specimens we could send to the CDC. Things began to change, of course, when we heard from the colleagues in the state of Washington about their own cases, and also when Trevor Bradford published about being able to sequence the virus. And then on February the 26th, we all heard in the news that the first community case had been identified. It was a case hospitalized at UC Davis. And the person who got infected actually had a very extended large family that part of the family lived up in the area near Davis, but part of them lived in San Jose. So we got a call that said, we need to do contact tracing because the family members of this person live in your community. So we began the investigation, but by coincidence on that same day, we also got a call from a clinician who was treating a hospitalized patient who did not have flu and had ARDS. And she thought that this person, regardless of the fact that there were no evidence of community transmission in California at that time, should be tested for SARS-CoV-2. And so we got permission from the CDC to somebody who had no risk factors, no travel to Wuhan, and to send that specimen and test it. And then really by the beginning of March, we were way into our recognition of what the community transmission was. And we started also dealing with questions such as, is this an outbreak? Like we had cases among workers of the San Jose airport that didn't have an epidemiologic link that was very direct, but they all were working in this very large workplace that is very hard to investigate given the amount of traffic that it has, how many people work there. And we needed a way to make sure that we enhanced that investigation. And we started working with UCSF at that time for doing the genomic sequencing. This is the it didn't get published until October of 2020, but this is the Washington State Bedford investigation report, where he was postulating, or the group really, because there were, by then there were persons from San Diego, UCSF, CDC collaborating. They were talking about potentially the SARS-CoV-2 infections in this area of Washington, maybe derived from a single introduction in late January. We, at the same time, work with Dr. Charles Hsu at UCSF and contributed our San Jose Airport specimens of patients that had a risk factor of working together in the same location. And we discovered that there were many different types of strains already in circulation, lineages, I should say, in circulation in California. Again, this was published in July, but this are cases from late January, February, and up to March, early March, from all areas of Northern California, in already finding different lineages that some of them had a very clear connection with Washington State, such as the ones that also were associated with the Grand Princess Cruise travel that had gone to Mexico, California, and the States, but some that was very unique. Everything happens, I think, in Santa Clara County. We found a strain that at the time there was no nomenclature definition of how to name it, and it became known as the Santa Clara County strain, and it was defined by the SNP right here at the very end of the sequence, which is not a useful marker, and it's also very difficult to detect. Sometimes when they're doing the sequencing, it stops because it finds a gap, or there's not a complete genome that can be sequenced. And sometimes it doesn't get all the way to the end, and it often, without looking for it, it gets missed. But we helped, I think, epidemiology and specimen collections helped the researchers, the genomic molecular biologists that were working on the technique to learn, because we told them, well, these two specimens need to match. They're like father and son, and you cannot tell us that they don't have the same lineage unless there's something we don't understand about transmission in a household. So they could go back and perfect the technique, and then they came up with this new, for Santa Clara County, lineage called Santa Clara, defined by this SNP right here. We published together on those multiple introductions into Southern California, but they also helped us and were our partners with defining it for Santa Clara County. What did we know? How could we define how the epidemic started, how did it get transmitted, and what had happened to those early lineages that we had in Santa Clara? We published this in late in the year, but we began. So we didn't publish until April 21st of 2021, but this is work done a year prior. This is another part of the uphill battle that we had to do. Public health departments at the county level are not that, perhaps, I don't know if to say interested, but not used to having a research area. And even though I consider what we did applied epidemiology and surveillance, having really support for writing a report and publishing was something that people were very busy and didn't have the interest at the time, and didn't know why a county health department could also contribute to the scientific knowledge and to, until we were fortunate enough that we all came to a good understanding. We have co-authors from academia, from the CDC, and we were lucky to finish this report that talks about the first cases from the very first one, a returning traveler from Wuhan, to March the 21st. This is an kind of a artificial cutoff of when we decided to close the cohort and send all the specimens to UCSF for genomic testing. We had also learned, in working with the coroner in Santa Clara County, that following Governor Newsom's instructions, they had looked at all the deaths that were suspicious and not diagnosed with a particular cause, that were, they did a look back to see if they were finding, if it was possible to find any cases of occult COVID-19 diagnosis. And they had found the earliest cases in a death that occurred on February 6th and February 17 that we included in our cohort as well. We, like I said, the viral WGS was done at UCSF, and they also did the bioinformatic analysis, and we merged all of that analysis with our case control and epi investigation that we did in public health. We didn't have a very good way to, well, we didn't have a roadmap or a previous investigation that somebody had published. So we came up with our own definition of how we were going to analyze the cases. We decided that since we had travel history, both to domestic and international sites for every case that we knew, we were going to try to see if the lineages discovered in the genomic analysis were consistent with the area of travel of the case. If we were lucky enough to have 2 or more specimens from an genomic sequences from an outbreak that we knew was either a household or a workplace or whatever type of epi-linked outbreak, yes, everybody at that time, all cases and even now are PCR confirmed, but not everybody, of course, had a sequence. So we had a definition of having outbreaks where we had at least 2 that we could match to each other, and we wanted to know if they were truly, if the genomics supported the epidemiology. The bioinformatics is really something that is tremendously interesting work that is done by the specialist, in this case at UCSF. At the county level, we used Clara to analyze the cases, and this is the epi curve of those cases. Interestingly enough, like I said, we had closed our cohort on March 21st so that we could analyze them together as a group, and we ended up with 140. We thought we were at 143 cases, but when Clara catched up with itself, we realized we were missing more than half. And by missing, meaning public health department wasn't missing them, but we didn't have the specimens, because whereas testing was only done through the health department laboratory or sending them through CDC at the beginning, on March the 5th, Stanford University developed their own testing capacity and offered it to the hospitals. There's 11 acute general care hospitals in in Santa Clara County. And so instead of the very delayed testing that could be offered through the public health, Stanford could do it much more quickly. But those specimens stayed in Stanford, and they also, of course, have a very robust genomic laboratory. But so we had the ones that were in the public health area. So we did analyze to see if the ones that we had, 101, were the same or different than the ones we did not know about the genomic sequences. We found out that our sequence cases did not differ by gender, but they were a little bit older, and they were a little bit more prone to have had a fatal outcome. Both of this is explained because at the time, we also were only talking about persons that were severely ill and hospitalized. This heavily represented here. We tested very few of the contacts that were living in the household. Only if they became ill with symptomatic disease was there an indication for testing. It seems incredible to say it now, but that's what it was then. We didn't have a race ethnicity differential, although Asian and Hispanic Latinx persons were more represented from the beginning and until this time in Santa Clara County than the other racial ethnic groups. We surprisingly found 17 different lineages amongst those 101 cases that we could analyze from the beginning of our epidemic. This is the bioinformatic work where this is a way of representing it. The trees, as you know, come in all kinds of shapes, but this tree I really like in that you can put more information when you're looking at the bigger picture. So at that time, using this GSED database, the bioinformaticians downloaded almost 20,000 genomes that were available in GSED, so that our genomes could be referenced against all the genomes that were available for public analysis at that time. So this is a representation of how the 17 different lineages that we found amongst our 101 cases fell. The one that is the Wuhan strain are the ones that are very closely related to the ancestral or the viruses that were recovered from China. But I already spoke that 40% of our sample included this lineage that nobody had described before, which is labeled Santa Clara. And then we had two other lineages that, again, we did not find in any place else amongst all the lineages that were published at the same time. And we, for convenience, labeled them Santa Clara. This is an outbreak around that first case that we had, where the clinician that I told you insisted on testing a community case that was hospitalized in her outbreak that happened around her. And this is a big outbreak in our family also in Santa Clara. We had WA1, which was the one that was published by the Washington State group. We had Solano County lineage, which is the brother, the contact of the case that had been first reported from UC Davis. So one of the contacts in our contact investigation was positive and could be sequenced and matched the UC Davis case. We had this, I'll describe it more, and 10 lineages that were each unique. When we looked at it through the travel history, we realized that travel history domestic didn't help us at all because there were mostly of 10 cases that had travel domestic history. most of them were actually of the Santa Clara County strain. But in the international one, which is not really fair, we already knew that the Wuhan travelers would have the ancestral strain. We had this couple that had returned from a trip to Europe and Egypt, and they had the B614G strain, which is at that time was called the European strain. And then we had some travelers that had gone to this Grand Princess cruise to Mexico and then returned to Northern California, and they had the WA1 strain. So yes, eight of the 11 with international travel match their origin of the lineage from what we thought, but 2 of them also were part of our Santa Clara lineage. And one of those, I'll only describe 2. The one, we thought that travel to Asia was the important thing in this cluster, but it turns out this person didn't have a strain that was published as part of the ones that came from Asia, but rather he was the father of a healthcare worker and also rented a space in his home for another healthcare worker, both of which worked in one of the hospitals that was most severely affected with cases in Santa Clara County, and they all had the Santa Clara County strain. This is the definition of the outbreak that we had in the San Jose airport. So while we had 7 cases of workers, they didn't really have a very close epidemiologic link, except they all worked at the airport. 3 of them were security guards. 1 was in the food industry, and 1 was the driver that goes between terminals. Some of them had outbreaks in their homes or transmitted to a healthcare worker taking care of them. We don't know if this is a workplace transmission, or is it just because this is the lineage that was circulating in Santa Clara County and they happened to get ill around the same time. We don't, in this case, genomic sequencing did not give the definition to the outbreak, workplace outbreak, that we wanted to. And in other instances, we did find outbreaks that we didn't know anything about, like we found a person of somebody who was linked to a cluster by, they attended the same church, and that wasn't part of their information that we had when we did the case investigation. We had a very interesting 2 cases that were found by the coroner and by CDC in analyzing tissue specimens post-mortem. And they happened to be both of the WA1 lineage, and the one that was the earliest on February the 6th, her death was on February the 6th, already had a genome that had all the 5 defining SNPs of the WA1, which meant that the circulation of that virus that she acquired and then ultimately was deemed as the cause of death was already at least a month and a half old, and she did not have any travel history. So it was an interesting recognition that there was an occult transmission, at least during the whole month of January, and perhaps even earlier in Santa Clara County. We published as well on the coroner's cases in Journal of the Medical Examiners. This is just a visual. I won't go through it a lot. Just to tell you, we had the 17 lineages, and in that particular lineage, we did the traditional epi investigation. This is what we call the Santa Clara count. This was our first community case that we knew about before we knew about the deaths February the 26th, an elderly lady hospitalized with severe pneumonia had cases. Her healthcare worker, the mother of the healthcare worker, and nephew all tested and could be sequenced, but they had a big distribution in epidemic terms in the whole household. This big other SEC3 outbreak that we had. So this is where the story differs a little bit. We had 4 cases of D614G. They were, at that time, I already said that they were, it was called the European strain. It was the one that we're looking in New York. They had a lot of cases like this. And in fact, they had a big outbreak in Boston related to a super spreader event that happened on February the 26th in a computing high-tech meeting that then seeded cases all over the county, but the United States. We had 4 cases of that type of lineage, D614G. We also were able to analyze what happened to those early lineages by doing analysis of all the genomes from only California, then collected up to March the 23rd. And we realized that our lineages, while they were very active during those first 2 months, most of them were not found again after a certain date, for example, May or June or July. And why was that? At first, we thought, well, it's just that we use it in a public database and they must be somewhere else. It's just that people haven't published their results. But it turned out that it was a phenomenon of one particular lineage becoming the more prevalent in all of California, and the other ones basically disappearing. And this is where the D614G lineage comes about. This is the one in red. So from June, July of the year of 2020, all this lineages turned to be D614G, and the ones that we had observed at the beginning, including the famous Santa Clara one here in purple, basically were not seen again. So D614G is the original variant. Now everybody knows also about variant, but in this case, the fact that this substitution added this G made this the more infectious type strain and the one that could take over the world at that time. We, like I said, at some point in late July, everything that could be sequenced was of that type of lineage. And that is what we also saw when we investigated the outbreaks in the long-term care facilities. So at the same time as we were working with UCSF, at some point, we realized that we needed a different type of partner for sequencing, because the academic world was doing it for certain type of research purposes, but BioHub, with the Chan Zuckerberg Foundation, was just starting their initiative for sequencing, and they also could partner with us. And so we created a surveillance system of the outbreaks that we investigated in long-term care facilities, defined as skilled nursing, intermediate care, and assisted living facilities in that exist in Santa Clara County. And we could use that learning to investigate those outbreaks. We, by this time, had developed a very robust testing strategy, and it included in congregate facilities. For those of you that are not familiar, we don't test just those that are symptomatic. Rather, once the outbreak begins, once there's even one single case identified within the facility, the same is done for flu, you test everybody around, around that. And in this case, around means the whole facility. So all healthcare workers, all residents of that facility get tested. We tested them weekly. Now they test them even twice a week. And until we get 2 cycles of no new cases, we stop testing. So we had a tremendous number of specimens, and we identified, along with the rest of the world, that there were many asymptomatic cases that were able to be transmitters of disease, because before we weren't testing anybody that was asymptomatic, but in congregate settings, we had to test the whole cohort of both residents and healthcare workers, like I was saying before. We had, in this time period, the first outbreak was identified in the middle of March, and in this time period of analysis, there were 41 outbreaks in long-term care facilities, and we focused our report on 6 of them. They are illustrated graphically here. They're all of the 614G lineage. We just arbitrarily named them with letters from A to D. These ones were all skilled nursing facilities. The ones that came later in the year, there are other types of facilities with memory care units. We did see that in the long-term care, where SNFs have the highest risk patients, they were affected first. I think that was observed in all the different communities that have different levels of cares. We also saw that they all had the same. If you can see now, there's a different type of phylogenetic tree, but this phylogenetic tree indicates one single introduction and a very rapid distribution in infection that happens very quickly. When they're all aligned like this, they're almost an identical number of genomes with maybe 1 or 2 mutations difference. This is the typical case. Most of the analysis of this file, all of them supported that there were an introduction, probably from a staff member, and then a distribution. There were about 3 times as many resident cases than staff. We had genomes from almost 200 of the 239 samples from this outbreaks. So very, very good coverage on sequencing. And then we had this very interesting outbreak here where you could see that this is a healthcare worker from this facility that worked in both. And we could identify that this person was likely the source of this outbreak. But by the time this strain infected the facility, it had acquired a SNF, and it made it a different lineage. So this was connected very well with the epidemiology of the outbreak. And this was also part of our findings that have now been reported very clearly in MMWR and others. So my main interest in telling you this story, which is now seems so old, and so many things have happened with genomic sequencing since we were fighting the battle of having it included in our epidemiologic investigations, is that really local and state level information is always going to be essential, because yes, we want to know what is the strain that is in the whole country, how to guide our interventions and the development of very important things like therapeutics and vaccine, and to monitor the trends over time. But really to understand the local epidemiology, you have to also do local level investigations, and control efforts need to be tailored to what's happening in your community. So the era of genomic sequencing is here, but normally for the purposes of the US, we use aggregate de-identified data. And my whole interest was that we would also learn that by doing investigations that are very local, we can learn a lot, and that in fact, usually epidemiology and genomics do match. Now, of course, nowadays, everything is Omicron. This blue line is Delta. This is also to make a plug for the very wonderful work that is done at the California Department of Public Health, where we have very good genomic surveillance data now for the whole state, and states can, counties can access their own data. And then lastly, because I thought some of you, although I know all of your faculty and I'm not looking for another job, but if you are interested, the HI program at CDPH is recruiting. In fact, there's a medical officer level 3 position in some high level epidemiology positions that are open just right now. And we have the opportunity to work in all parts of California, because right now we have a remote works opportunity. So anyway, I hope that you all allow me the fact that I make this shameless plug for anyone who wants to take on a new career like I did at this time. Thank you.
Elsa, that was wonderful. Thank you so much. And I love that comment on your last slide about the nerd immunity. That's what we have to remember. So let's go ahead and open it up to questions. We've got about just about 10 minutes before we have to jump off to our faculty meeting. So I see that Dr. Anderson has her hand raised. Would you like to go ahead and ask your question?
Yes, thank you, Richard, for facilitating. Elsa, I thought that was an absolutely fascinating and brilliant presentation. Thank you so much for doing it. And it's interesting because it made me feel like just yesterday when I was hearing the reports of this, new case up in the Davis area, and we weren't really sure if it was the first evidence of community transmission. Anyway, that said, my question for you is about partnerships. And you had so many pearls in your talk today about collaborations across academia, the county, when you were developing the report, sort of how you got people to really come to the table and sit there and be great partners. And I, here in San Diego, am noticing that with us having a School of Public Health, we might have an interesting opportunity when it comes to public health laboratory services within, whether it's the San Diego region, or even if you think about extending all the way up to Los Angeles. And so my probing with you today is really about how do we think about the large lab resources that we have on the campus, right? If you look down at our county health department, it's a shell of a laboratory. And we saw that during COVID, where the response was largely dependent on what the academic researchers could do here at UC San Diego. So what examples, if any, are you seeing about what we should look to for the future? Because if COVID has taught us anything, is that shell of an infrastructure is not going to cut it. And so where do you see really great examples of, the academic public health units or, other lab units coming together with county health departments to really do that kind of work that you all were able to do?
Excellent. I think that is exactly something that I'm passionate, that message about discussing. So in Santa Clara, actually, the public health lab, when I arrived, they said, oh, we're concerned our public health lab is not as it should be. And I had just come from, well, anyway, I thought people don't really know what they have. This is like the most wonderful public health lab, and it's so well resourced. It has such good connections with the state laboratory. Just the location and the way it has been grown and led. They had a very strong sequencing program already for PulseNet, and I thought it was great. But then I realized that we were in a privileged position, and that even us with that privileged position didn't have everything that we needed. We were lucky that the CDC at the beginning, was interested in communities like ours where there were a lot of cases happening. So we developed a good relationship with them so that we could send the specimens, even trying to push the envelope when they had very strict criteria what type of specimens to send. Well, we would get on the phone. I would get on the phone sometimes and call around people that I knew and said, you need to accept the specimens. So we did a lot of bridge building that requires time and requires interest and requires not giving up. And I remember when we were looking for the sequences of the first two cases, the traveler cases that came, they CDC published the identified data, and we needed to have somebody tell us in the GSA database which were the ones that belonged to Santa Clara County, because they were not identified to the county level. So we knew by date, but we couldn't tell which ones they were. So that started, I said, well, that's not unusual because we're at the very beginning, but that then somebody said, oh, up the road, UCSF has this. So basically, if we had a need, I or somebody from my team knew somebody who could call. And at that time, the fact that we were all learning together, it made everybody interested in collaborating together. One interesting thing always happens, for example, with further up the road at Stanford, we had the opposite reaction when we called, and not to speak bad about them, just when we called, they politely said, we have our own genomics lab, and we will eventually, publish, yes, to the published database, but right now, public health doesn't need to know anything except positive or negative in a PCR. We're not sharing anything else. So not everybody is ready to share early, but I think that most people were, and most people did it selflessly, didn't think, well, if I share right now, then where will my publication go? The other thing that I learned is that Santa Clara County, while as advanced as they were as a public health department, they were very, very traditional. And even one thing, for example, this preprint mode that didn't exist before made them completely nervous. They said, no, we have to wait, peer-reviewed journal. And I kept saying, I come from that too. I come from the CDC where it takes, 3 years to publish anything because of the clearance. And no, it has to be. And I said, but we have to change with the world. The same way we're using genomic sequencing to enhance our investigations. Everybody uses preprint right now because you get the feedback from the other scientific community, and you're not saying, you clearly say this is not has not been peer reviewed. It could change by the time, but if you keep it until you get that that input, a year later, what good does it do you in this day and age? You have to modernize with the times, and I think that if we get more people that think alike, that believe that, yeah, the research is important, but the public health impact and the way we can serve our community, whether we're in academics or whether we're in a investigative lab or whether we're in public health, we can all do the work together better. Very good. I hope that UCSD goes down that track and has a lot of collaborators.
Great. We have 1 minute left, and I'm going to ask them, I'm going to take prerogative and just ask a very quick question. So hopefully it'll be a quick answer, which is, I think back to when I was an EIS officer and I had to do an outbreak investigation of a case of hepatitis C that was transmitted to and from an anesthesiologist, and how important the genomics was in that case, because we, had to make sure it was actually traveled that way. And I can see now that this is a very important area in epidemiology. So my question for you is, do you think that maybe genomic epidemiology for the purposes of outbreak investigation should be part of the curriculum in like an MPH program? Sounds like a lot of good information that we need people to know about.
Yes, I think so. I think that is the same. When hepatitis is a very good example, Richard, because the genomics, for example, are much more complicated. And whereas, yes, you can use genomics to define some of the epilinks or dispute some of the epilinks, it's not as clearly a good teaching as perhaps COVID will be. I think you could choose any of the diseases, COVID, of course, being the most relevant. And of course, the one that has shown us from the beginning till now, how the genomics grew along with our understanding of disease transmission through the basic epidemiology investigations and how to couple them together. So yeah, I think that it would be a very interesting course for your curricula.
Great. Thank you so much, Elsa. We really appreciate your time and all the pearls of wisdom that you shared with us, and we hope to see you again soon. Thank you, everybody.
Thank you. Have a very good day. Bye-bye.
Bye-bye.
Bye, thank you.